Hello, I'm Bobby Jean Schweitzer, and I'm going to talk about endocrine and metabolic systems 1. So the lecture modules will contain diabetes mellitus and parathyroid function and disease. Let's start with diabetes mellitus. So the diagnosis of diabetes is either type 1 or type 2. Type 1 is defined as insufficient production of insulin. These are typically younger patients, and they present with failure to thrive. Type 2 is insulin resistance, and this typically occurs in older patients. They often have central obesity and a high glycemic diet. The pancreas produces approximately 50 units of insulin daily in normal individuals. It is primarily triggered by blood glucose levels, and insulin is also an important anabolic hormone. You can see that the continuum of insulin action varies from relative decreased insulin action in type 2 diabetics to an absolute decreased insulin action in type 1 diabetics. So let's do a question. A 67-year-old type 1 diabetic presents to the preoperative clinic for evaluation. Which of the following are common comorbidities? A, myocardial ischemia without symptoms. B, autonomic neuropathy. C, gastroparesis. D, limited joint mobility. Or E, all of the above. And all of the above is the correct answer because all of these conditions can occur in diabetics. So insulin increases both glucose and potassium entry into muscle and fat cells. It also activates processes that lower blood sugar, including the production of glycogen, fatty acid, and protein synthesis. Insulin decreases processes that raise blood sugar, such as glycogenolysis, or breakdown of glycogen to glucose, gluconeogenesis, which is an increase in glucose, ketogenesis, production of ketones, lipolysis, breakdown of fat, or protein catabolism. The diagnosis of diabetes can be made in a variety of ways. If one uses a hemoglobin A1C level, a level of 6.5% or greater, diagnoses diabetes, though this may be inaccurate in patients with anemia, those with abnormal hemoglobins, such as sickle cell disease or thalassemia, and those who have undergone recent blood transfusions. If a patient has a fasting blood sugar of greater than or equal to 126 milligrams per deciliters, or international units of 7 millimoles per liter, this is diagnostic of diabetes. Fasting is defined as having no caloric intake for a minimum of 8 hours or more. In the past, oral glucose tolerance tests were used a lot more frequently. These have become much less common currently, but this consists of a 2-hour, this consists of ingesting 75 grams of anhydrous glucose and then measuring glucose level. And a 2-hour postprandial glucose after the 75 grams of glucose ingestion of 200 milligrams per deciliter or greater, or international units of 11.1 millimoles per liter or greater, defines diabetes. Any clinical symptoms of hyperglycemia, such as polyuria, polydipsia, or unexplained weight loss with a random glucose level of greater than or equal to 200 milligrams per deciliter, is also diagnostic of diabetes. The timing of the glucose is not important in this latter setting if there are symptoms present. So what is the perioperative management of patients with diabetes and hypoglycemia? Well, there's no absolute cutoff for a preoperative blood glucose level or hemoglobin A1C, though some studies have shown that elevated A1C levels are associated with higher risk of complications, and typically for either cardiac surgery or neurosurgery, elective procedures are delayed for hemoglobin A1Cs of greater than 8 to 8.5. And the recommendation is that blood glucose levels be maintained at all times at less than 180 to 200 milligrams per deciliter, but typically above 110 milligrams per deciliter. Tight glucose control has been associated with harm as well. Typically in the perioperative period, IV insulin infusions are favored over either subcutaneous or IV boluses. Pre, inter, and post-operatively, it is much easier and safer to control glucose with intravenous infusions than their sub-Q or IV bolus. And this is especially important post-operatively in patients undergoing cardiac surgery and organ transplant patients. It's also important in patients who have type 1 diabetes while they are fasting, and for any critically ill patient where the fluctuation in glucoses can be rapid and dramatic. Any patient who has a diabetic ketoacidosis is typically not a good candidate for anything other than truly emergency surgery. Diabetic ketoacidosis is much more common in type 1 diabetics, but can occur even in type 2 diabetics. This is due to either a significant lack of insulin for some period of time, but can occur within 24 hours of no insulin in a type 1 diabetic, or due to significant illnesses, even if insulin is still being administered. Infections, trauma, myocardial infarctions, major GI bleeds, severe illness, and surgery are all reasons to cause a patient to go into DKA. The presentation of DKA is typically an altered mental status, lethargy, even coma, abdominal pain, nausea, vomiting, polyuria, polydipsia. Patients are often hypotensive, tachycardic, tachypnic. They have significant electrolyte depletions and an osmotic diuresis secondary to the elevated blood sugars. Laboratory findings consist of an anion gap, metabolic acidosis. The way to calculate an anion gap is to take the sodium minus the chloride plus the bicarb level. If this level is greater than 12 millimoles per liter, that is considered an elevated anion gap. There sometimes are mixed disorders though, especially if the patient has nausea and vomiting, which may cause a metabolic alkalosis on top of the metabolic acidosis from the DKA. Patients who have lactic acidosis is particularly common in patients who may have infections or rhabdomyolysis or hypotension. Patients who have uremia, there are often increased ketone levels. In fact, that's the sine qua non of diabetic ketoacidosis, is the patient does have increased ketones either in their blood or their urine. Beta hydroxybutyrate and acetic acid and is a byproduct of acetone account for this. Typically, glucose levels are markedly elevated, 400 to 800 milligrams per deciliter, though you can develop DKA with essentially normal blood sugars. Hypercalcemia is present despite a total body deficit because of the shift of potassium from intracellular to extracellular, and so there is a risk of severe hypocalcemia with insulin treatment as it moves potassium back intracellularly. There's a pseudo-hyponatremia present. The total body sodium needs to be corrected for the glucose, and usually it is entirely normal. The BUN is typically elevated due to prerenal azotemia or dehydration. The patients are hemoconcentrated and often have leukocytosis. They have hyperosmolality. Amylase and lipase may be elevated, and there may be a high CPK level because of concomitant rhabdomyolysis. So what is the treatment of DKA? Well, the absolute treatment requires the administration of insulin. Again, intravenous insulin is much more predictable because there is variable absorption from sub-Q injections in patients who have hypotension and dehydration. One can transition to sub-Q insulin when the bicarbonate level becomes normal. Typically, you continue the infusion for about 2 to 3 hours after the subcutaneous injection of insulin to allow for the absorption delay. The initial resuscitation is with isotonic 0.9% sodium chloride or lactated ringers. When the blood glucose level is less than 200 milligrams per deciliter, one typically should start a D5W and continue the insulin to treat the ketogenesis. You should add potassium chloride to the IV fluids when the potassium is less than 4 and urine output has been established, and you know that the patient is not in complete kidney failure. Glucose should be checked at hourly during the initial insulin infusions. After that, they can be spread out a little further. Electrolytes and arterial blood gases can be very useful and are typically checked frequently to guide corrections. Nonketotic hyperosmolar states are more common in patients with type 2 diabetics, particularly older patients. This is typically due to both a lack of insulin as well as a kidney dysfunction, cognitive impairment, and inadequate oral intake. Precipitators are typically systemic illnesses, infection, myocardial infarction, patient having a stroke, or developing bleeding or falls, and may be more common in hot weather or in conditions where patients do not have air conditioning. The laboratory findings in non-ketotic hyperosmolar states are similar to DKA, but there is typically a much milder metabolic acidosis. They have a non-GAP metabolic acidosis with a pH that's usually 7.3 or above. There's no ketones present in a non-ketotic hyperosmolar state, hint, hint. They're usually a severe hyperglycemia, severe hyperosmolality. Osins can be greater than 320 millimoles per kilogram. The sodium is inappropriately normal despite dehydration, and there often is an elevated BUN or creatinine due to the significant dehydrated state. So the management is vigorous rehydration, typically starting with isotonic sodium chloride solutions. One should be measuring and correcting electrolytes, measuring and correcting hyperglycemia. Again, IV insulin is much safer than any other route. One needs to diagnose and treat underlying diseases, as there's often a precipitating factor. Obviously monitoring cardiovascular, pulmonary, renal, and central nervous function, particularly in this elderly population. Frequent monitoring of glucose and electrolytes, not dissimilar to DKA. Sometimes endotracheal intubation may be indicated for comatose patients. Let's talk a little bit about the other spectrum of glucose control, and that's hypoglycemia. Hypoglycemia is most commonly a complication of insulin therapy. It's much more common in type 1 diabetics. They're considered to be much more brittle. It's defined as a glucose that's less than 70 grams per deciliter. The symptoms, which typically are not present until the blood glucose gets to be less than 50 grams per deciliter, include altered mental status, dizziness, lightheadedness, diaphoresis, fatigue, delirium, and even seizures. And remember that many type 1 diabetics will have minimal to no symptoms of hypoglycemia. So what is the treatment? Well, it's immediate administration of glucose. If the patient has an intravenous line, 50% dextrose, which is D50. Typical amp is 50 milliliters, so giving a half to a full amp intravenously. Or one can administer 20 to 40 grams of dextrose gel orally. These are typically little packets that in plastic that you rip open and squeeze under the patient's tongue or just into their oral cavity and gets absorbed across their mucous membranes. One should maintain an infusion of D10W for some time, especially if the cause was related to insulin. Frequent blood glucose monitoring is obviously necessary. Adjunctive options can include glucagon, which is typically usually reserved for patients who do not have IV access or you do not have access to dextrose-containing solutions. This can be given as a 1 milligram IM or IV bolus. Hydrocortisone to empirically treat adrenal insufficiency, since that may be the cause or associated with other causes that cause hypoglycemia. And octreotide, which is synthetic somatostatin. It can suppress insulin release, typically used in patients who have insulin secreting tumors. Let's talk about parathyroid function and disease next. So a question: a 40-year-old female with a history of hyperparathyroidism may have all of the following complications related to hyperparathyroidism except A. Kidney stones, B. Weight loss, C. Abdominal pain, D. Joint pains, or E. Osteoporosis. Which one of these is not related to hyperparathyroidism? And the answer is weight loss. So answer B is correct because hyperparathyroidism is not associated with weight loss. Hyperthyroidism is associated with weight loss, and sometimes those two conditions can be confusing, particularly if one is quickly reading. Answers A, C, D, and E are all incorrect, as these are classic symptoms of hyperparathyroidism and complications of hypercalcemia, which results from the hyperparathyroidism. So what does your parathyroid do? Well, it regulates serum calcium. It typically regulates it in a very narrow range of 8.4 to 10.2 milligrams per deciliter. Remember, most calcium is bound to albumin. Ionized calcium is the active form, which is the free form of calcium. And your ionized calcium level is typically in a very short range of normal of 1.1 to 1.35 millimoles per liter. When your ionized calcium is less than a half a millimole per liter, typically one will see tetany and or arrhythmias. When your ionized calcium level is elevated, typically greater than 1.7, that results in typically altered mental status and comatose states. The pictogram just shows you the interaction between calcium, vitamin D, and parathyroid hormone. So primary hyperparathyroidism is most commonly secondary to benign adenomas of the parathyroid, about 90% of the time. And the presentation is typically described as bones, stones, groans, and psychic overtones. But often the patients are asymptomatic and they are just discovered to have hyperparathyroidism because they have an elevated calcium level. The patients are at increased risk of nephrolithiasis, the stones part, bone demineralization and fractures, and skeletal muscle weakness and fatigue. This is the bones part. Epigastric discomfort, peptic ulcerations, pancreatitis. This is the groans part. And delirium, confusion, psychosis, and coma. That's the psychic overtones part. Patients are not uncommonly hypertensive, and they may have ECG changes if they have marked hypercalcemia. The typical ECG changes of hypercalcemia, which usually don't occur until one's calcium level is in excess of 11 to 12, is a short QT syndrome, PR prolongation, a narrow QRS complex, heart block, or bundle branch blocks. So what is the treatment of hypercalcemia? Well, initially it's just hydration, unless the patient has a kidney failure. So diuresis can flush out calcium. If the patient doesn't diurese with just IV hydration, then one can use loop diuretics such as furosemide. Furosemide not only causes a diuresis, but it also inhibits calcium absorption from the top proximal tubule. One can treat chronic hypercalcemia with bisphosphonates, calcitonin, and glucocorticoids. This prevents osteoclastic bone resorption. It is not an instantaneous treatment. One typically needs to treat the associated hypophosphatemia that goes along with hypercalcemia. One should monitor the ECG, treat hypertension if it's associated, and remember to discontinue thiazide diuretics, which, unlike furosemide, actually increases serum calcium levels. And what about anesthesia for a patient with who's going to undergo a parathyroidectomy? Well, it's become standard of care to monitor the recurrent laryngeal nerve function, similar principles to that occurs with thyroid surgery. A second IV is often needed for monitoring of calcium and parathyroid hormones, because these are usually done in real time now to assess whether they have identified all of the adenomas or hyperplasia that can cause hyperparathyroidism. Careful positioning is always important to prevent osteopenic fractures. Propofol can interfere with intraoperative parathyroid assays, so often TIVA with propofol is relatively contraindicated. It is not felt that induction doses of propofol would typically be a problem. Complications of parathyroid surgery include hoarseness or stridor from unilateral or bilateral even recurrent laryngeal nerve injury, and respiratory failure and tetany from the rebound hypocalcemia that can occur after the parathyroid have been removed. There's also a syndrome called hungry bone syndrome, where these clastic osteopenic bones are sort of starved for calcium, and there is a marked uptake of calcium. So it's important to monitor the calcium, magnesium, and phosphate levels for approximately a week or so after surgery. So what about the other extreme, and that's hypoparathyroidism, which typically occurs secondary to parathyroid surgery and not de novo. The symptoms are related to the cardiovascular, musculoskeletal, and central nervous systems typically. Cardiovascularly, hypotension, heart failure, arrhythmias, and ECG changes, specifically a prolonged QT, are the most common cardiovascular implications. The musculoskeletal system problems occur with muscle cramps and weakness. Central nervous system, the irritability. The patient can have laryngospasm, stridor, tetany, or seizures from the low calcium levels from hypoparathyroidism, and altered mental status, including dementia, depression, or psychoses from hypocalcemia. So what are the anesthetic implications of a patient with hypoparathyroidism? Well, you want to replete the calcium, and you want to avoid myocardial depressants. You want to avoid alkalosis, which means avoid hyperventilation, and judicious use of bicarbonate therapy. If you administer any citrate-containing blood products, they may bind calcium further and lower the calcium levels. Avoid 5% albumin, which will further decrease calcium levels. Monitor for progressive coagulopathy, which is also a complication of hypocalcemia. And judicious use of non-depolarizing muscle relaxants, because the patients may have increased sensitivity. That means avoid judicious use of non-depolarizing muscle relaxants. Thank you very much for your time.